Hi, my dear viewers, subscribers. Good evening to all once again. In my medical laboratory speech presentations, I came up with an important another topics related to the proteins and non-protein nitrogenous substances. As you know, what are proteins and its classification and the different type of proteins. You know, it is very important in the laboratory diagnosis as well as in the medical uh, laboratory services. So I'm going to take up my topic, that is protein. What is proteins? Proteins are uh, high molecular weight polymers of low molecular weight monomers. Proteins are what is the important properties of proteins and the important properties. One is it is a denaturing property. Proteins usually in normal, they have native proteins cannot be denatured in their structure and composition, but in some instance they may be denatured by using some agents, so they have gone for a denaturation. Their structure and composition will be changed. And second is the reducing property. Total proteins react with biuret reaction, an alkaline copper sulfate with tartarate, Rochelle salt, sodium potassium tartarate. They form purple colored complexes. That is one properties of proteins. That is the biuret reagent is the heating of urea at 180 degrees Celsius. That is another properties of proteins. And also electrophoretic properties of proteins. One is the proteins are act as a colloid in the solutions, and they move towards one subject when they are subjected to electric field. So proteins are anions, and they are subjected to anode when they applied electric field. So albumin is on a isoelectric pH of about 4.8 and globulin 6.3. Isoelectric pH means the pH at which proteins are neutral, it does not carry any charge. So depend upon their molecular weight, size, pH, isoelectric pH, and pH and surrounding mediums of the medium, they are undergone a electrolytic movement. So albumin is lowest size and move fast with subsequent alpha 1, alpha 2, beta and gamma globulins. And veronal buffers are used in the electrophoretic pattern. So veronal buffers so used in serum electrophoresis, study about some disease of proteins. And plasma electrophoresis, there may be a band appears in between alpha and beta gamma globulins. These are the properties of proteins. And different type of proteins. What are different type of protein? Plasma proteins, albumin, globulin, alpha 1, alpha 2, gamma globulins are secreted from the liver and hepatocyte of liver. Gamma globulins are produced from the plasma cells. And another proteins are prealbumins and prealbumin and retinal binding proteins synthesized from the liver. And the low molecular weight proteins, prealbumin can bind T4 and T3, and retinal binding protein bind vitamin A. Prealbumin level is increase in Hodgkin disease, decreases in inflammation, liver cirrhosis, malignancy, etc. Retinal binding protein increases in liver disease, decreases in malignancy, renal failure, as well as zinc deficiency states. Another protein is called, these are the proteins, different type of proteins. And another type of proteins are used in the proteins metabolism is our haptoglobulin. Haptoglobulin is a glycoprotein which can binds extracorpuscular hemoglobin. Extracorpuscular hemoglobin is in 10% of hemoglobin is degraded and that is released to circulation. That's extra. So this free hemoglobin can easily escape through the kidney. So before it is haptoglobulin binds and haptohemoglobin complex is formed. So it helps in the an escape of the free hemoglobin and is used for the iron and synthesis and hemoglobin synthesis. Haptoglobin low is found in the hemolytic anemia. Next is transferrin. Transferrin is a beta 1 globulin synthesized in the liver and it is transport iron. It transport iron for the where it is for iron is necessary for the body. So transferrin plasma concentration of transferrin is 300 milligram per deciliter. So this transferrin can bind about 300 microgram of iron per deciliter. So that's called total iron binding capacity. And transferrin decreases in the hemolytic anemia and increases in the hemochromatosis. Next is ferritin. Ferritin under normal condition, ferritin stores ions. Ferritin contains 23% of iron, and where it is when the hemochromatosis iron utilization, iron necessary for the body's increases, so ferritin also increases. That is about the ferritin. Next is ceruloplasmin. Ceruloplasmin is a beta alpha 1 alpha 2 globulin, and it is synthesized as a liver, and 90% of copper is synthesized at transport by the ceruloplasmin, and it is a blue color in quantity because ceruloplasmin. Ceruloplasmin is decreases in Wilson disease. Wilson disease is a copper deficiency syndrome, and its accumulation of cannot excrete the copper into bile, and its accumulation of bile in the liver, brain, etc. cause hemolytic anemia as well as neurological disorders. This and alpha 1 alpha 2 macroglobulin, it is increases in the nephrotic syndrome, and alpha 1 macroglobulin, alpha 2 macroglobulin is especially released by the lymphocyte and tumor cells. So there is increases in the renal defect, and is an excellent marker for tubular function, and it is in the kidney transplant patients, due to the allograft rejection, the use as alpha 2 macroglobulins are used in that sense. Then next proteins are C-reactive protein. It's acute phase protein like fibrinogen, ceruloplasmin, C-reactive protein, alpha 1 antitrypsin, alpha 2 macroglobulins are acute phase protein. They are increase in the infection and inflammation. C-reactive proteins are increase in myocardial infection, stress, major surgery, trauma. In these conditions, C-reactive proteins are increases, synthesized in the liver, and it is binds to polysaccharides of bacteria and fungi and parasitic infection. It causes opsonization, phagocytosis of invading organisms, and this increase in the infection C-reactive proteins after 12 hours increases and declines in 48 hours. As in the myocardial infarction, it is increases 48 hours and increase up to 2000 times folder than normal. Next is alpha 1 antitrypsin. It is increase in the liver cirrhosis as well as in the renal failures, etc. Then we come to proteinuria. What is a proteinuria? Glomeruli behaves like ultra filter for protein. So protein, high molecular weight protein like IgM cannot filter in the glomerulus. So albumin also a low molecular weight and high plasma concentration, it also filter in the glomerulus. A small amount of albumin is escape through the urine, about 20 or 150 milligram per day. So albumin escape in the urine is some pathological problems, factors. There are 5 types of proteinuria. Increase protein albumin present in the urine is called proteinuria. Glomerular proteinuria due to increased glomerular permeability, tubular proteinuria due to tubular defect, and overload proteinuria due to the abnormal low molecular weight protein in the urine like Ben-John protein, myoglobin, haptoglobin, and postrenal proteinuria due to abnormal concentration of protein in the urine, and functional proteinuria like functional proteinuria due to fever, thyrotoxicosis, fever, exercise, etc. One what is how to detect the protein? Protein detected in the urine by 24-hour urine protein. Usually for a random purpose we are using protein creatine ratio. So creatine is constant for every individuals. So urine protein creatine ratio, if ratio is 3.5, there is a nephrotic type of glomerulonephritis type of syndrome, etc. And if it is 0.2, less than 0.2 is a normal urine protein excretion. Next is microalbuminuria also there. Microalbuminuria means increased urinary albumin excretion, as well as total protein excretion is less than 150 milligram. And there is a early marker for diabetes mellitus, which is we have studied in the previous classes. These are the protein. Then the protein total proteins are detected by biuret reaction. Albumin are detected by bromocresol green and bromocresol purple methods. Total proteins is increase in dehydration, as well as albumin and globulins also increase. Total protein decrease means albumin decreases in the impaired protein synthesis, protein catabolism. Next, protein malnutrition, albumin increases, and heavy loss of protein, albumin in the urine, nephritis, liver cirrhosis, and in the protein catabolism like fever, as well as in the protein malnutrition, albumin decreases in the blood and found in the urine also. And edema, what is meant by edema? Edema means when the total protein is less than 5 milligram and albumin is less than 2.5 milligram, and edema will occur. Edema means escape of the water from the blood to the tissues, that is called edema. And globulin increase is found in the advanced liver diseases like in multiple myeloma, and like chronic disease like tuberculosis, rheumatoid arthritis, subacute bacterial endocarditis, diabetes mellitus, and as well as lupus erythematosus, SLE. This is the protein metabolism, and protein metabolism which are studied about proteins, and different type of proteins are used in the laboratory and their diagnosis. Next we go through the non-protein and nitrogenous materials. Non-protein and nitrogenous materials is nitrogen balance, urea metabolism, that is end product is urea, amino acid metabolism, end product is urea. Urea metabolism is the ketone deamination occur in the liver, and ketoacids and ammonia. Ammonia is very toxic. Ammonia is converted to urea as end product of the amino acid metabolism. Azotemia is a high nitrogenous non-protein aerosol increase in the decreased urea excretion, increased blood protein metabolism, and decreased protein metabolism, like pre-renal, renal, and post-renal conditions. Urea will be clinical significance of urea. Urea determination by Berthelot method, as well as rate of reaction dioxide monoxide method. Berthelot method, we have clinical significance of urea like pre-renal condition, fever, diabetic, thyrotoxicosis, fever, cardiac failure, burns, trauma in this condition, and corticosteroid problems, and bleeding from the gastrointestinal side, urea is increased, blood urea is increased, as well as renal condition like glomerulonephritis, nephrotic syndrome, tubular defect, severe kidney disease, urea increase. Post-renal condition due to obstruction of the urinary tract, due to enlargement of prostate and tumors of the bladder, urea will increase. Blood urea decreases in the pregnancy, in liver disease, as well as protein malnutrition. Next, we move on to creatine metabolism. Creatine is found in the muscles, so it is end product of creatine. It's an anhydride of creatine is called creatine. Creatine metabolism. Creatine is the end product of the creatine metabolism. It is produced from the creatine phosphokinase, as well as creatine as not an essential. It is synthesized by the body by lysine, arginine, and methionine. So creatine is end product of creatine metabolism, and is a waste product, and it was present in the muscles, etc. So serum creatine increases in the renal failure, shock means blood pressure fall, congestive heart failure, and obstruction of the urinary tract. Serum creatine values increase. Serum creatine values diagnostic for renal failure is creatine value 1.5 to 2 milligram per deciliter. It's an exact marker for renal failure. Serum creatine. Serum creatine methods are for Jeffy reactive method with alkaline picrate methods were used. Alkaline picrate. Next, we are study about uric acid. Serum uric acid is a end product of the purine metabolism. From the xanthine and hypoxanthine urate oxidase. So uric acid increases called hyperuricemia, decreases called hypouricemia. Uric acid increase up to from 7.2 milligram is called hyperuricemia in males, and 6 milligram per deciliter increase is called in females. Uric acid increases in leukemia, uremia, renal failure, gouty arthritis, and decreases in the Fanconi syndrome, heavy metal poisoning, tubular defect, and galactosemia. Uric acid increase called gouty arthritis. Gouty arthritis in the joints, deposition of urate crystals, monosodium